Good afternoon, respected members on the dais and distinguished friends. So I shall be talking about clinical differentiation between Pythium and fungal keratitis. There are challenges in differentiating these two infections. I have no financial disclosures to make. So let's take with a case example. This patient had come to us with a corneal ulcer that clinically appeared to be fungal, and the direct microscopy reports also showed of the scraping showed fungal filaments. So we treated the patient with antifungal drugs, but the case worsened, and we advised a therapeutic keratoplasty. The initial period was uneventful, but soon she came back with florid recurrence that soon progressed to perforation, and we lost the eye. Meanwhile, the report of the corneal button had come, and it had grown Pythium insidiosum. So we had been treating this patient as fungal keratitis while it was actually Pythium keratitis. But what had happened with us is not uncommon. Misdiagnosis has been commonly reported in the literature, and it is mainly because clinically the fungal ulcer appears like the Pythium ulcer, and on direct microscopy, both the filaments are sometimes very difficult to differentiate. So we thought if clinical signs can be a clue, if they can aid in the diagnosis of Pythium initially, so that we can have avoid such poor outcomes. So we did a retrospective comparative case series where we included culture positive Pythium keratitis and culture positive fungal keratitis and examined their clinical reports and archived photographs. So these are the signs that have been reported in literature for Pythium keratitis and fungal keratitis, and we concentrated on these signs. So there were 27 patients with Pythium keratitis and 69 patients with fungal keratitis. Amongst the demographics and the risk factors, an absence of trauma was noticed more commonly in patients with Pythium keratitis. Trauma was associated with fungal keratitis. Although, excuse me, the age of the Pythium patients was slightly younger than fungal keratitis. It was not significantly different, but the symptom duration was same in both. However, the ulcers of Pythium were larger and the vision was poorer, more severe infection. If we look at the excuse me, if we look at the clinical signs, dry surface, which is classically associated with fungal keratitis, was seen more often in patients with Pythium keratitis. Plaque was much more present in fungal keratitis. Hivate ulcer margins was much more present in fungal keratitis, but tentacles were more commoner in Pythium keratitis. Intrastromal dots were characteristic of Pythium keratitis, but they were also seen in patients with fungal keratitis. The reticular pattern, which is a very classical sign, was also seen in patients with fungal keratitis. Peripheral furrow, that is now recognized as an important sign, could also be seen in patients with fungal keratitis. And a ring-shaped ulcer was much more associated with Pythium keratitis than fungal keratitis. Other signs like color of the stromal infiltrate or the satellite lesions were not found to be statistically significant. We did a multivariate logistic regression, and where we found that a peripheral furrow and presence of tentacles were more associated with Pythium keratitis than fungal keratitis. So we thought that these clinical signs, although they were associated with fungal keratitis, but awareness of the clinical signs would alert the ophthalmologist in the clinic to make a presumptive diagnosis of Pythium keratitis. They in turn can alert the microbiologist, who can be more careful in their evaluation of the corneal scrapings. And sometimes when this, the situation is, culture reports are ambiguous or negative or delayed, then this clinical approach can be helpful in the clinics to make a therapeutic decision. Ophthalmologists who do not have access to microbiology can recognize these signs, and they can, refer the patients early, because Pythium progresses very fast and can have a poor prognosis, poor outcome if treatment is delayed. If we go back to our patient whom we had misdiagnosed as fungal keratitis, we found that he had tentacles, reticular pattern, and intrastromal dots that were not picked up. So it is possible to differentiate Pythium from fungal keratitis, but there is overlap of signs, and none of the signs can be considered as sine qua non. So one solution is to develop a clinical score by combining these signs into a compact score, which we have done, and we presented the findings in the morning. And however, I would like to clarify that clinical approach or clinical diagnosis can only be an adjuvant. It does not replace the role of microbiology. For microbiology's evaluation remains the gold standard for diagnosis of any infectious keratitis. But the clinical approach can be an adjuvant and can actually help the clinician when the microbiology reports are ambiguous, delayed, or negative. Thank you.
Very good presentation, Dr. Chatterjee. What is the difference between the treatment protocol in these two cases?
It's completely different because Pythium keratitis needs to be treated by antibiotics. Currently, azithromycin is one, linezolid is the other. There may be more antibiotics, but they cannot be treated with antifungals. They do not have ergosterol in the fungal cell wall, so the antifungals do not work. But because fungal keratitis is more prevalent, so when you have a case that is that overlaps and you don't have a good microbiology report, the fungal filaments and Pythium filaments, sometimes they are very, very difficult to differentiate. Then the obvious tendency becomes to treat it with antifungal drugs because of the prevalence. Pythium is around, studies reported from 1 to 6%. In our setting, it is around 1.4%. And fungus is around 50%. So you can commonly misdiagnose a Pythium for fungus. But these signs are actually helpful more if we combine them into a clinical score. And we presented that clinical score data in a previous presentation in the morning. And that is more helpful than just picking one sign. So it has to be a comprehensive approach with the clinical signs.
And a typical history found in Pythium?
See, typical history that we found and also that's reported in literature is absence of trauma. So, but that's again a very vague history because normally we associate a vegetative trauma with fungal ulcer. So maybe a clinical ulcer that appears to be fungal and patients deny a history of trauma, then you can probably suspect that maybe it's Pythium and look much more into the microbiology, alert the microbiologist. If clinicians are alerted, then they can in turn alert the microbiologist and they can pick up more signs.
In your group of Pythium keratitis, you didn't find any trauma? No one gave the history of trauma?
Less trauma.
In your series?
Yeah, in my series also. In my series also, the percentage of trauma was much more in the fungal keratitis.
But there was
yeah. So there's an overlap of signs, even history. Some studies, I think from Shankar Netralaya, they had not presented any trauma in one of their papers, and few of the initial case series of 2 or 3 cases did not have history of trauma. But trauma can be there. Or sometimes maybe the trauma is missed and the patient doesn't associate it with it.
Trauma again with this typical vegetative material like we see in
trauma with anything in fact. Vegetative matter is a secondary infection that occurs. Even in bacterial keratitis also you'll get a history of trauma sometimes even with vegetative matter. So the trauma creates an epithelial abrasion which can then get infected either by fungus or bacteria depending on what the patient is exposed to.
In general ophthalmological practice, it's not an uncommon thing that we see that the patient, usually they mix antibiotic with antifungals. How do you see that?
But here the antifungal that they mix is what moxifloxacin, and it has not been found to be very useful with Pythium. So we're using linezolid, which we have to make it, or azithromycin, which is also not a very common frontline drug. So because it progresses rapidly, in our case, the case worsened in days. So a comprehensive ophthalmologist treating this with both moxifloxacin along with antifungal drugs and then calling the patient after 3 days or 5 days, by that time the case would be out of your hand. So initially only if you suspect that, okay, this doesn't look like a typical fungal ulcer, better that I should refer it to a place where they can do a corneal scraping. That would be, so that is actually the aim, and that's why I put this first part of the paper in the comprehensive, this thing to alert comprehensive ophthalmologists that if you see these signs in a patient with a corneal ulcer that appears to be fungal. Now candida and dematiaceous have typical features, so this is mainly for the hyaline fungal filaments. So at that time, best is to send it to a place where there's a good microbiologist, and the microbiologist knows how to pick up the Pythium.
You said culture was positive for Pythium. So which culture media you had used?
We have done blood agar. So blood agar is not the definitive culture medium, but it gives a kind of a typical colony. It's a flat colony, grayish, translucent type of a colony, which is homogeneous. And from there you can again get the filaments. But normally the diagnosis is you have to use some other techniques where it includes seeing the sporangiophore. It's not done. Even our microbiology is not equipped to do that. Most of the microbiologists cannot do that. And DNA, that's if the government RT-PCR labs, they can get this thing, what you call, generalized into other investigations of the COVID is over, maybe. Otherwise, diagnosis culture is difficult.
Even filaments, they are like ribbon shaped, and they've got some vacuoles or vesicles inside the filaments.
Yes.
So that is quite characteristic about Pythium.
Yeah, but then if you see, I had quoted it, a recent paper from L.V. Prasad. They had actually done a sensitivity amongst 3 microbiologists, and all these 3 microbiologists were experienced ones who first reported. And there also the lower limit of the confidence interval is 79.3. So from such a big center who have been seeing Pythium for 7 years, they are in 20% of cases, they are not able to identify it on direct microscopy.
Thank you, Dr.